I am Jagat Narula. I am in the CVN studios with three stalwart interventionists and the atherosclerosis researchers. On my right is Dr. Spencer King, who is the editor-in-chief of JACC Interventions from Emory and St. Joe's, Atlanta. I have Dr. Amir Lerman, professor of medicine from Mayo Clinic, and Dr. Samin Sharma, who is the director of the cath lab, as well as the president of the Mount Sinai Health Network, and from Mount Sinai, New York. So in this issue of JACC imaging, we are presenting a provocative article where we are proposing that if it is possible to identify intact fibrous caps in the cases of acute coronary syndrome, so-called the plaque erosion, we should be able to do away without a stent if the lesion is non-obstructive. So let me ask Dr. Amir Lerman first, that until now, we have always talked about plaque rupture and plaque erosions as a pathological definition, which has been the post-mortem definition, as has been shown in Michael Davidson's studies and the systematic data presented by Dr. Virmani. What do you think? Has the time come that we will be able to classify the plaques by the clinical means?
First of all, thanks for inviting me. This study is very provocative and thought-provoking. And I think we base all our data currently on autopsy study, an elegant autopsy study. And I think time has come to move forward with a new imaging modality to the first time maybe characterize the plaque underneath STEMI or non-STEMI, which may revolutionize the way we treat this patient. So I think your question is correct. Based on this and other data, we may need to move forward with more prospective study to characterize the plaques.
Dr. King, you think it is rather premature to take this leap of faith, and don't you think it is something very intuitive? Do you want that the more data need to be accumulated before we are able to propose this as a paradigm shift in the management of such patients?
Sure, I mean, I think it's a wonderful idea, and I love imaging, and I love to see what these look like, but I'm not ready to say this is going to make a big difference in the way we manage patients. For a long time, when we've had, say, a STEMI patient and the artery is totally open, and we could prove that with intravascular imaging, is there an addition to adding a stent to this whole story? We don't really know. The common practice now is these all get stented, as you know. But I don't know whether it's erosion or even plaque rupture, that if there's no obstruction at the end of the day, whether a more conservative approach might be the correct one. But I think we need more data. I don't think we're ready to jump in to a clinical application of this routinely.
Dr. Sharma, let me ask you, you are the biggest proponent of the guidelines as well as of the appropriateness use criteria. Looking at the guidelines, how do you reconcile with not doing a stent in a particular subset of cases, be it rupture or erosion, and specifically erosion as we are talking about in this particular case?
Yeah, Jagat, thank you for inviting, and then more important, this very provocative article which will be published. The question, once it is obstructive, I think answer is very simple. Guideline, you stent it. What is stent, and so now latest coming that maybe the mesh are better because of the latest stentis and the master's trial with the MGARD, that by keeping that thrombus into the vessel wall and not embolization gives you better short-term and long-term results. The question comes if it's non-obstructive. I think based on the guideline, you have to leave the lesion alone unless you prove by some additional testing, which has not been done yet, that because you're uncomfortable, you then do additional OCT or IVUS and show large thrombus burden still, but not obstructive, or with the FFR. Again, the data has not been shown, but if you're uncomfortable with a non-obstructive lesion, want to be sure, done the OCT, FFR, and both still say non-significant, I think then, of course, those lesions should be left alone. But as far as the guidelines at this time, and this we face every day in our clinical practice, patient got MI, got thrombolytic, or some cases not even thrombolytic, 2 days later they show up, and vessel looks a little hazy, but obstruction is only 30-40%. Clearly there were the EKG changes, there was a regional dysfunction in that vessel territory, so that there's no question the patient suffered MI, but now is left with a non-obstructive lesion. And whatever the gut feeling is different each case, we may need to prove that it is not going to reocclude again, but majority of the time those cases should be left alone.
Dr. Lerman, what will be the economic impact of avoiding these stents if at all it becomes possible that we can reasonably identify these plaques which do not have plaque rupture?
That's a good question, and I think before we move to economic, we need to be sure that we're all physicians and that the safety of the patient and doing the right things for the patient comes first. From economic standpoint, I think that we need the study to prove it. In every study that we do now, we introduce an economic factor. Of course, if you do an OCT alone and leave the patient on medical therapy based on randomized study, then I think you may have some economic benefit. So I think the economy is a moving target, but I think it certainly calls for a prospective randomized study to see how we treat these lesions.
Thank you. Please look for this manuscript in the JACC imaging issue of March with an elegant editorial from Dr. Jean Braunwald from Brigham and Women's Hospital, and a very excellent debate which has been between Dr. David Holmes and Dr. Ami Lerman on one side, talking about see, think and act, and on the other hand from Dr. Pedro Moreno, Dr. King and Dr. Sharma, which says just act. So we will look forward to your views. Keep writing to us. Thank you.